Thank you so much, and it's a pleasure and a privilege to be here talking about how we are trying to really transform drug development for vascular disease. I'm going to be talking about precision long-term therapies, and I'll tell you what that is about in a minute, for genetic vasculopathies, and this in particular for diseases that are affecting children in a devastating manner. And this will not be possible without the team that we have been able to assemble together at MGB, Harvard, and you can see many more universities working together, as well as regulatory experts and the Center for Gene and Cell Therapy. And the expertise brings the possibility of really developing the technologies that can change the way we're doing therapeutics. So let me tell you about what disease we're trying to tackle. Vascular disease. What is vascular disease? Number one cause of death and disability in the world. Still, to this day, despite all the treatments, preventive measures that we all are supposed to be doing, and let me tell you that no one here is spared from this disease, by 80 years of age, your aorta starts to have atherosclerotic plaques. So despite everything we know in the medicine and the standard of care that we have, accessing to these therapeutics and the treatments that we have are still not preventing the number one cause of death and disability. What are the symptoms of vascular disease? Stroke, MI, kidney failure. You're very familiar with this because there are a lot of our patients in the hospital and a lot of our families are affected by this. And as you may or may not know, 80% or more of cardiovascular and cerebrovascular disease is caused by vascular disease, vessel wall disease. And as we said, we need several years to develop vascular disease when you don't have a gene at the root cause. But if you have a genetic vasculopathy, that can happen in months after birth. And you can literally have a stereotypical atherosclerotic disease with an MI at 6 months of age. And these are the children that I also take care of in the ICU and at MGH and Harvard. So we have decided to transform the way that we're doing therapeutics for vascular disease. We want to do this one patient at a time with all in mind, and now you'll see what I mean with this. And that will be only possible if we are able to transform the tools that we have to access the vessel wall. So the how is here. We need a platform of delivery vectors, LNPs, AAVs, and whichever ways we can to concentrate the drugs into the vessel wall to heal them. We really are aiming at preventing and healing and halting the vascular disease. As you know, vessels and the mechanisms are convergent, and there are two main mechanisms. Your smooth muscle cells, the ones that make the vessel wall, are dysfunctional, or you have calcium inside the wall that allows to have the plaques, that we call them, to rupture and occlude the vessels, and that's when you lose blood flow and you have your heart attack or your stroke. The vessels can also rupture if the vessel wall is not functioning. So in these both mechanisms, we have prototypical monogenic hereditary diseases. And we also know that if you are trying to target sporadic vascular disease, if your drug is working on a genetic, in a gene pathway that has been discovered or identified in population studies by the genetic studies on GWAS, you are more likely to succeed in your clinical trial. And guess what? These rare conditions that I'm talking about are the genes at the top Manhattan plots of these GWAS studies in large population studies. How did we go at this with our team? We knew that we needed a better way to get concentration of the genomic therapies that we wanted to deliver to the vessel wall itself. And we started with taking these therapeutic agents, in this case, ways to modify the DNA of the cells in situ, that's by CRISPR-Cas genome editing, or by adding the gene that is, in these cases, loss of function, and it can be enhanced to prevent, for example, calcification of vascular disease. I would not have time to talk about the calcification disease, but I will tell you the story that we have now in front of the FDA, and we're pursuing IND-enabling studies. So to get to the vessel wall, you need to go across the endothelium and target these smooth muscle cells in the brain. These are also the pericytes, which are critical for blood-brain barrier function, as you know, critical for neurodegeneration. So we were able to evolve an AAV9 called AAVPR that effectively, selectively, and specifically targets the vessel wall, the endothelium, the pericytes, and the smooth muscle cells, and is the only one that exists. And we didn't just do this in a mouse, and we thought about doing this in non-human primates, as we now select a lot of our vectors there. But in reality, we are a hospital system. So we took samples from patients' arteries alive and perfused them in a bioreactor and tested if we can do better than the benchmark, which is in this case AAV9. And we are way above the performance of AAV9 in targeting the cells inside the vessel wall in human vessels. So let me tell you why I'm here. This is why I'm here. This is my patient, and she was 8 years of age. In this picture, she's singing Frozen. She didn't know she had a disease that produces narrowing of the vessels in the brain because of dysfunction of the smooth muscle. And unfortunately, a few months later, as they were trying to help her with those palliative surgeries that I was talking about we use these days for vascular disease, she strokes the majority of her brain and is now bedridden, ventilator dependent, cannot walk, cannot talk, and has very little communication capacity. So this is the reason why we're doing what we're doing, and we must get things done. And this is why I talk about one patient at a time with all in mind. These are very few patients in the world. The disease can be diagnosed at birth. The kids are born with fixed dilated pupils. All teams will rush into the scanners because they seem to be herniating. In reality, it's the smooth muscle in the eye that is not working. It's caused by mutations in the actin gene. The cells cannot contract. They start proliferating. They narrow the vessels in the aorta. They weaken the vessel wall to the point that they rupture around 10 to 15 years of age. So they start walking. They give us a window for treatment from birth to walking, and then they start having strokes. And in the second decade of life, they can start dissecting the aortas if they're not surgically replaced. So we develop and engineer a bespoke enzyme, CRISPR-Cas-based editor, to target the cell, the single letter in the DNA that is abnormal in this disease, in the smooth muscle cells and correct it. We were able to do this in vivo, in mice, in early stage of the disease, in advanced stages of the disease, and we have much higher efficiency than doing this with any other vector known that has been used in humans, such as AAV9. And very importantly, we did a lot of work in trying to make sure that this is a safe approach, that our off-target profile is very beneficial. The most important thing, we don't only increase the survival by more than fourfold, we're able to completely reverse the vasculopathy. You can see the artery wrinkle in the normal, totally dilated without the function of contractility in the mutant mouse, and then vascular normal function with normalization of blood pressure, an excellent biomarker for early efficacy in clinical trials that also prevents neurodegeneration. In these cases, very catastrophic. So here we have a proof of concept that we can fix the aorta, the cerebral vasculature, even the kidney vasculature, and prevent neurodegeneration in a disease by an in vivo genome editing. And our work has just published last week by chance in Nature Biomedical Engineering, if you want to see more of the details. And we are not thinking about these only few patients with this particular variant in the ACTA2 gene. And as you could imagine, they have this moya-moya type of vascular disease in the brain, the vessel narrowing. These are just the variants that we can do with the exact same enzyme that we have. We are thinking an umbrella platform. We are proposing to the FDA to use the same enzyme, vary the guide, and go after multiple different variants for moya-moya disease and aortopathies. And this is more than 10,000 patients. And here's how we go from one to all, and in a way of de-risking one type of delivery at the same time that we are performing and developing the lipid nanoparticle, which will accelerate and decrease the cost of manufacturing as we translate these diseases and these modalities into these different platforms. We have a very robust portfolio of IP, and as you can see, the pyramids are extensive. The bottom part of the second one is millions, and I think we can do it. And this is also going to be accelerated by the LMP. So where are we at? We have orphan designation, pediatric indication, an FDA Interact, a pre-IND, fully aligned with the FDA on IND-enabling studies that we are taking on our own right now. And we are really looking for partners to take us to the next stage with the strategic partnerships to be able to expand this pipeline of therapeutics. Thank you.